Yes, good morning, everyone. On behalf of the NIDA International Program, I would very much like to welcome you to today's session and to the overall CPDD meeting. I have a very short role here because I know there's a very full agenda, and we are on a fairly tight schedule as we have been generously afforded this time before the main CPDD meeting. And as part of that, we've agreed that we will try our best to end our meetings, Tuesday, Wednesday, and Thursday on time so that it doesn't interfere with the meeting. So having said that, let me introduce you to the overall chair for today's session, which I think is going to be very interesting and very important. You all know Anya Usif, who's a program officer at the Prevention, Treatment, and Rehabilitation section at UNODC's Drug Prevention and Health Branch. NIDA has been very much interested in as much of a partner as we could be in the development of the standards, which I think we can all agree is critical and essential as we move forward in addressing the health problems due to substance misuse around the world. So having said that, I will turn it over to Anya. Thank you again all for coming and participating.
Thank you very much, Steve. Really, thanks so much for NIDA and CPDD in this case for hosting us, for having us, for giving us this platform to present today on the international standards for the treatment of drug use disorders. And I would like to give the floor first to Giovanna Campello. She is the Chief of the Prevention, Treatment, Rehabilitation section of the United Nations Office on Drugs and Crime in Vienna, and she will give us some opening words. Giovanna.
Thank you, Anya. Thank you, Steve. Thank you, NIDA International and CPDD for having us. It is my great honor to welcome you at the UNODC WHO Symposium on the International Standards for the Treatment of Drug Use Disorders. And my WHO colleague, Dr. Vladimir Pozniak, the unit head of the Alcohol, Drugs, and Addictive Behavior team in WHO, cannot be here with us today, unfortunately, but sends his best regards, wishing all an interesting event. And it's a great honor for me to speak on behalf of both of us. Let me start by extending our gratitude to all of you for participating and thus signaling your interest in science and human rights-based treatment of drug use disorders. Let me also thank NIDA International Forum for generously hosting this event and continuously providing a platform for collaboration and exchange among researchers from all around the world. We use the platform a lot, and we hope to continue to do so for a long time. UNODC and WHO are also very grateful to the government of the United States of America for supporting the development of the international standards for the treatment of drug use disorders. And Dr. Andrew Thompson, Narcotic Science Advisor at the Bureau of International Narcotics and Law Enforcement Affairs of the US Department of State, a mouthful, a friend and colleague from INL, is here with us today. The international standard for the treatment of drug use disorders are a very good example of how, by working collaboratively in the framework of the UNODC WHO program on drug dependence treatment and care, for almost 12 years now, WHO and UNODC have demonstrated their capacity to develop technical guidance that is of direct relevance to UN member states, civil society, and people with drug use disorders all around the world. With the complementary mandates of UNODC and WHO, we continue to bring together relevant stakeholders across sectors to address drug use disorder and its negative health and social consequences in a comprehensive and interconnected way. Now, this week is a special week. It leads up to the 26th of June, with the official name of International Day Against Drug Abuse and Illicit Trafficking, or in short, sometimes called the World Drug Day. Now, this year's motto is Share Facts and Save Lives. And I invite you all on Friday, actually tomorrow, at the launch of the UNODC World Drug Report. And I believe Share Facts and Save Lives is a motto that also unites the drug use disorder research community and service providers, that we are as we are working together to translate science into practice to ensure evidence-based drug use disorder treatment service provision in the framework of quality drug treatment systems that are committed to ensure accessibility and quality of person-centered care and thus save lives. Share facts to save lives could also have been a guiding vision for the UNODC WHO international standards for the treatment of drug use disorder that we'll present to you today. All of the speakers in this event were either part of the development, the field testing, or the implementation of the international standards. I hope all of you listening today are as excited as me to hear from them in this truly international panel. Steve was just mentioning how we have at least 11 time zones represented on the panel today. And I also hope that the symposium will fill you with motivation and enthusiasm to take our message out to your communities and to continue to work hand in hand with UNODC and WHO to ensure qualified and effective responses to drug use disorders, promoting the human rights and the dignity of people with drug use disorders, their families, and their communities. Let me say that this is especially important in the challenging time like this when we are all going through a global pandemic. Our Secretary General, the Secretary General of the United Nations, has said that we are only as strong as the weakest in our society, and people with drug use disorder face increased risk of COVID-19 related morbidity and mortality. In this regard, let us all join forces to promote the prioritization of people with drug use disorder in the COVID-19 vaccination schemes whenever and wherever we can. Improving coverage of substance use disorder treatment is an agreed global development priority outlined in the United Nations Sustainable Development Goal, specifically in Target 3.5, and the implementation of the standards will help us reach this goal. So in conclusion, I'm very happy to be here today, and on behalf of UNODC Prevention, Treatment and Rehabilitation Section, on behalf of my colleagues in the World Health Organization, I wish you all an inspiring and fruitful event. Thank you so much.
Thank you so very much, Giovanna. And now I would like to give the floor to Dr. Andrew Thompson, who has already been mentioned from the US State Department. He's there, as Giovanna said, the science advisor at the Bureau of International Narcotics and Law Enforcement, INL, to also give us some opening remarks, and for a very good reason, as Andrew, I'm sure, is going to tell us in a second. Andrew, the floor is yours.
Great. Thank you so much, Anya. And thanks to everyone for joining us this morning, afternoon, evening, whatever the case may be. Before we dive into the session, I just want to take a minute to talk about why I'm incredibly proud of the projects that you're about to hear about and why I see them as some of the most important things that I've had the privilege to work on in my time with INL. When we go around the world, one of the most pernicious challenges that we face in the area of substance use prevention, treatment, and recovery support is the stigma that's placed on people who use drugs and people who suffer from substance use disorders. The stigma is seldom something that's sort of outright said. More often it appears as an implication or an attitude that people who are suffering from substance use disorders are somehow responsible for their own suffering, that they aren't deserving of quality care, or that the resources that are being spent on their treatment would be better spent elsewhere. The UNODC and WHO international standards begin from a radically different point of view. And it's the idea that individuals with drug use disorders deserve nothing less than ethical and science-based standards of care, similar to the standards used in the treatment of other chronic diseases. Yesterday, if you were able to attend this forum, you heard a little bit about some of the challenges that can arise when training is not backed up or followed up by adequate technical assistance that ensures that whatever principles and practices were conferred during training are appropriately implemented, and that without this follow-up, we risk backsliding, we risk the implementation of practices that are not effective, and as a consequence, people and governments may lose confidence in treatment and recovery as a viable response to the world drug problem. So in my view, the international standards and the quality assurance mechanisms that are being developed from them, as well as the other work of UNODC and the World Health Organization that we're going to hear about today, are an important vehicle for that critical follow-up work. by defining the standards of quality care and taking the time to build treatment systems based on scientific evidence around the world, we're pushing back against the stigma. And more importantly, we're sending an affirmative message that the lives of people with substance use disorder are worth saving. So I just really want to emphasize that that's what I see as the critical value of these projects. But that's enough from me, and I'll turn it back to you, Anya, so that we can get on with this and hear from the true experts on the call. Thanks.
Thank you so very much for these opening words and the remarks, Andrew. This is much appreciated, as much as really the support and the leadership that we've had from the US State Department and the backup to develop all these products. If I may ask Christina to start bringing up the first slides, and while we do that, let me also just say, for those that are attending the site event, if you want to have questions or comments, at the bottom of the screen, there is a Q&A function, and we would like to ask you to use this Q&A function rather than the chat, and we'll try to respond during the session there. So that being said, I'll give the floor to myself to give you a very quick background to the development of the UNODC WHO International Standards for the Treatment of Drug Use Disorders that we are presenting in depth today. Next slide, please. So as you know, and the new data will be launched tomorrow, as Giovanna said, the world situation with regard to drug use and drug dependence looks at, we have roughly 5.5 seems to be the new data, percent of the global population between 15 to 64 who have used at least once an internationally controlled substance in the past year. And of those, over 35 million people are suffering from drug use disorders that would need treatment. But the access to treatment is very, very limited, with only 1 in 8 people having access to treatment, and that still doesn't say anything about the quality. Next slide, please. So as Andrew already mentioned, quality of treatment for drug use disorders is often low. Even it's often well-intentioned, but if it doesn't follow scientific evidence, even then it can be ineffective or harmful. So it would also surely not be a good investment of public resources. And also drug treatment systems are also often not designed in line with public health principles. Another reason really also to do and develop the treatment standards was that there was a need to stop human rights abuses that are committed in the name and the wrong use of the name drug treatment. And that what we want to see, of course, is drug treatment that shows symptom reduction, that shows kind of biopsychosocial improvements in individual well-being, and that decreases the risk for negative health and social consequences. Next slide, please. The International Drug Control Conventions ask that all parties, so all member states to the UN that have signed the conventions, should take all practical measures for the prevention and treatment for people that suffer from such disorders. Next slide. And this kind of lack of quality, or for, let's say, quality assurance and standards, has also been recognized by the Commission on Narcotic Drugs, that asked in 2009 for the development and adoption of appropriate healthcare standards for the area of demand reduction, so for prevention and treatment of drug use disorders. Next slide. In the same year, in 2009, UNODC and WHO launched our joint program on drug dependence treatment and care, through which we have been implementing now for nearly 12 years on global, regional, and national level support to member states in improving their responses to drug treatment. In 2016, as an outcome of this joint collaboration, we published and launched for the first time the International Standard for Treatment for Drug Use Disorders as a draft for field testing. Next slide. This document was immediately recognized at the international policy level, and the Commission on Narcotic Drugs passed a resolution encouraging member states kind of to use these standards, and for UNODC and WHO to disseminate the standards and support countries in their implementation. Next slide. And even at, let's say, a higher level in international policy making, the General Assembly that met for a special session in 2016 also had, the standards were available, and the General Assembly asked for their promotion and implementation. Next slide, please. I also just wanted to add that for a scientific community like the one we are meeting today, it's of course very clear that drug use disorders are biopsychosocial health disorders, but I think we also should not underestimate the importance that, again, the General Assembly in the same outcome document also recognized drug dependence as a complex multifactorial health disorder. Next slide. And as hopefully all of you also know, that prevention and treatment are also very much part of the international development agenda agreed in the Sustainable Development Goals. Next slide. So coming back to the standards that, now let's say we're in the years between 2016 and 20 really had a strong scientific and a strong policy backup, and the field testing of the standards took place in a number of countries, and we will hear from two examples today. Next slide. And with that, I'm closing my introductory presentations and invite you, of course, to, after the session, have a look at the standards that are there to assist member states, countries in the development, expansion, improvement, quality assurance of both their drug treatment services and systems. So they have a service and a system level component. Next slide. And with that, thank you very much for your attention. And we are now going to watch a video from our colleague, Dr. Dimitri Krupchanka from WHO, who gives you more details about the field testing of the standards. Dimitri.
Dear colleagues, thank you for the opportunity to present at the NIDA International Forum. And I'm sorry for not being able to make this presentation live, because we have in parallel WHO Forum on alcohol, drugs, and addictive behaviors going on. But let me take you through the process of developing international standards for the treatment of drug use disorders. As mentioned in previous presentation, it was done within the framework of joint WHO UNODC Program of Drug Dependence Treatment and Care. And the document aims to support and guide member states in development and expansion of treatment services for drug use disorders that would be evidence-based, effective, and ethical. And we went through quite a long and comprehensive process of the document development. The work has started in 2015, when groups of international experts came together, built a skeleton and key elements of the document. Then we integrated available WHO and UNODC publications into it, also looked into additional literature available in the field. Then we also included all available WHO guidelines, recommendations, for example, on opioid agonists treatment, the community management of overdose, management of mental health conditions, etc. But then, of course, we realized that it's important for documents of this type, which is built for a global audience, that it's not just developed by experts, but the country had chance to contribute, and countries tried to use it in their settings, and then to ensure the utility and appropriateness of the document. So therefore, after developing the initial draft, we initiated a process of field testing. But then even the initial draft of the document was very well received by the international community. It was mentioned in several high-level resolutions, such as the one you see here, the C&D resolution 2016. But what's even more important, it was highlighted and recommended within the UN General Assembly special session on the world drug problem, where standards are recommended for implementation in countries. And then, as I said, the field testing process was done in 9 countries with different health system structures, with different levels of economic development and from different regions. And basically within this field testing, we wanted to ensure that the standards are applicable and they have utility and the feasibility for implementation in a variety of settings. A lot of work has been done for the 2 years when field testing was implemented. As you see on this slide, more than 1,000 participants provided their opinions in the survey. Then there were more than 40 external expert reviews, 300 participants in focus group discussion, then also more than 40 site visits done within the field testing. And I will try to present you results in 2 slides. So here you see the 4 dimensions across which the standards were evaluated. So for example, on the utility, if participants of surveys and focus groups think that it's useful, and then you see the green bar suggesting that the majority of participants find document useful, appropriate, comprehensive, and more questionable feasibility, where maybe thirds or more than thirds of the participants of field testing considered that there are issues related to how to make their system aligned with these relatively high requirements highlighted in the standards. And then, of course, there are a range of barriers. I don't have time to show you details, but just in this cloud, like a major words associated with the bottlenecks for standards implementation, you see a couple of words like resources, training, that the systems might be not developed enough, that there might be a lack of professionals and lack of knowledge in professionals, etc., etc. The range of barriers taken into consideration. And then also we used these comprehensive materials collected during field testing to update the document. And I should say that this update was quite significant. The document was restructured, many new elements added. For example, new subchapter on comorbidities was included. Then many language editing, trying to make language more friendly, more correct, and also expanding interventions in some places. So it's quite a remarkable change. And currently the document has 5 chapters, and I think the 3 chapters, they play an essential role, such as the key principles and standards, then description of treatment systems, and also going into details for a variety of treatment settings, such as inpatient, outpatient, outreach, rehabilitation, recovery management, and also key interventions, including pharmacological, psychosocial, and then also, as I said before, section on comorbidity of drug use disorders with mental and physical health conditions. And of course, the chapter on adaptation of the standards to population with special needs. So now when we have this beautiful document in hand, we are very hopeful that countries will be interested to take it and try to update and reform their systems and to improve access and quality of treatment provided to people with drug use disorders. And with this, I think that next speakers will provide you more details on country level perspective. Thank you for your attention, and I hope to see you in future.
Thank you very much, Dimitri, and we will now bring the slides up again, because as said, so the field testing took place in 9 countries, and we have examples actually, and 3 presenters from 2 of the countries who will share with us about the field testing experience at national level. And it's my pleasure to give first the floor to Dr. Eva Suriani and Dr. Cristiana Siste. Dr. Eva Suriani will present as a psychiatrist at the School of Medicine and Health Science at Atmajaya Catholic University in Indonesia. Eva, the floor is yours.
Thank you, Anya.
You have muted yourself.
Oh, sorry. Yeah.
Right.
Thank you, Anya. So good morning, good afternoon, evening, colleagues. I would like to thank WHO, UNODC, and NIDA, also CPPDD, for giving Indonesia the opportunity to present the result of the field testing that we conducted from January to May 2018. So I would like to give all of you a brief outline of my presentation. I will explain three parts of field testing that we test at Atmajaya University and University of Indonesia as a field testing center. Next slide. So for the key informant survey, we got 115 respondents with 70 clinicians and 45 other relevant professions like administrator, public health, and outreach, etc. We found that these standards are useful and comprehensive to facilitate improvement in coverage and quality of treatment for drug use disorder, while there are some issues regarding the feasibility and the appropriateness. There were many participants concerned about the lack sustainability funding to run the standard because our national health insurance still doesn't cover drug use disorder. This situation led to the unaffordability of the treatment for patients who need it. Health facilities that serve drug use disorder are also inadequate and don't reach a remote area. The lack of human resources that can handle these services ranging from outreach workers to specialists. There are also doubts about the appropriateness of an individual right to get intervention voluntarily and could drop out of any time that wants. This is the centrally difficult in Indonesia because of the low level of education as well as the unwillingness of patients to take the treatment due to their addictive condition. Next slide, please. Move on to another part of the field testing, 5 local expert review. We got few topics that were underrepresented for the standard. It was about eliminating stigma from beginning for health worker through training from their medical institution and for the community through a drug use prevention curriculum in collaboration with the Ministry of Education. The need for coverage by national health insurance systems for the treatment of drug abuse disorder that we explained earlier, the need for inclusion of intellectual and development disability population as a special population, the need for more detailed treatment guides as from specific drug, dose, duration, etc., and the need for good coordination with the criminal justice systems. Slide. From the two focus group, we encounter several feasibility issues, especially for the naloxone take-home program, which still not can be implemented in Indonesia, as well as the needle exchange program and condom distribution that are not in line with the culture and norm that exists in Indonesia. Public will see the condom distribution and needle exchange as attracting more patients into it. Screening with biomarker that must be done on a massive scale certainly require no small amount of money. Withdrawal conditions are limited to certain drugs, so we can add standard with other substances. The existence of family-oriented therapy also turned out to be quite difficult to do because of the patient refusal to involve their family due to the stigma they get. Extra working hour is quite difficult to implement because of the funding. Government should also closely monitor long-term residential treatment setting and access the program success. Next slide, please. Yeah. So this leads me to our conclusion that the international standard for the treatment of drugs abuse disorder are comprehensive and useful to facilitate improvement in the coverage and quality of treatment for drug abuse disorder. There are several feasibility and appropriateness issues when applying to the standard Indonesian culture and social systems. So many resources like training, human resources, facility, financial support, policy support are required to implement this international standard. In the last slide, next slide please, we have our collaboration center that was helped with our field testing and our team. Thank you so much for listening. Thank you, Anya.
Thank you so very much, Eva, and to the entire team for actually embarking on helping us to field test the international standard. That's much appreciated. And I think, later on we will have a presentation on overdose management. Maybe there is also something, you can take home back to Indonesia. And I'm also happy to just share that on family-based treatments. In the meanwhile, we have jointly done a feasibility study in Indonesia that therefore maybe can help already with addressing some aspects around the feasibility that came out as a challenge during the field testing phase. Thank you so very much.
Okay, thank you.
With that, let me kind of move us from Asia to Latin America, where also field testing took place. And I would like to give the floor to Dr. Carlos Ibanez, who's psychiatrist and chief of the addiction unit at the School of Medicine at the Universidad de Chile in Chile. And he will speak about the field testing experience in Chile. Carlos, floor is yours.
Thank you. Thank you for the opportunity of sharing the results of the field testing of the standards in Chile. I will use the same structure that Eva has just used for the presentation. It took place in 2018. Next slide, please. Well, the first stage was the key informant survey, an online survey that were answered by 150 professionals, both public health and clinical professionals that work in addiction field. They considered that almost all principles were useful and appropriate. And only, like Dimitri said, only around a half things that most of the principles were feasible. Most of this informant think the principles are comprehensive enough. The main barriers that the informants identified were insufficient financial resources and trained professionals. Next slide, please. When we interview the local experts, in general, they think that the document was a good one that broadly addressed the treatment and substance use disorders, that emphasized the respect of the rights, of human rights of the persons in treatment, has clear principles and has an adequate evidence support. They find that the key principles and standards were exhaustive, suitable, and were clinical utility and can be applied in a staggered way in this cultural context. And they think that it will help to improve the quality of services in Chile. The treatment modalities and settings that were described are in general precise and well explained. They are viable and of clinical utility. Although the pharmacological treatment focused exclusively on opioid substance use disorder. Fortunately, in Chile and most in Latin America, there's not a big problem with opioids. And well, we have a big issue with alcohol, and it is very necessary that this aspect is treated in the all guides that work with addiction treatment population. Although the special population chapter is suitable, feasible, and clinically useful, is not exhaustive enough since it does not include many other important special population. We mentioned in that report the necessity of talking about dual disorders, comorbidity. The service delivery system chapter could include the concept of universal health, integrated health service networks, and interdisciplinary health teams of PAHO. It's about that it's look like too much a net that it's not communicated enough with other health necessities. It's like the parallel networks of treatment systems, the health, physical health, and the mental health, not addiction, and the addiction system. It's more necessary to explicitly include the coordination, we think, at the system level. Next slide, please. And the last part of the field testing that I'm going to present is the focus group. We have 3 focus groups with some team participants. Well, they find that the modalities, the settings described are relevant and appropriate to the national reality. Again, the overemphasis on opiates and a neglect of alcohol and smokable cocaine. That's a problem, the smokable cocaine. It's a Latin American problem too. Cross-cutting issues that should appear in several therapeutic modalities are developed exclusively in one of them, which generates confusion and lack of clarity of the document. There was like one setting that described aspects of the treatment that it's common for the many other settings. Importance of having manuals or technical guidelines that allow specifically implementing the indicators. And the community-based outreach and recovery managed modalities will signify an improvement of the substance use disorders treatment system in Chile. And the other modalities, the other settings described, we have already a set of standards and a quality assurance system that it's in place, and both the first modalities are very not included yet in the quality assurance system in Chile, and it's very helpful to have them. Next, please. So the final conclusion is that the document is comprehensive, appropriate, utility, and feasibility, and are adequate in general, but require some adaptations to implement it to the Chilean context. The utility and appropriateness of almost all criteria is high, although feasibility of the majority of the standards is around 50%. There is an overemphasis on opiates and neglect of alcohol and smokable cocaine. And the main barriers identified were insufficient financial resources and trained professionals. Thank you.
Thank you very much also for this review of the 2016 version of the standards from the perspective of Chile, which was very, very relevant. And I hope all of you that have been participating in the field testing found that some of the changes or some of the things you have identified were reflected in the 2020 version. So now let's say we make the shift from 2016 field testing, and now in the agenda we move to 2020. And I would like to give the floor to my colleague, Dr. Wataru Kashino, who is a program officer also at the Prevention, Treatment, Rehabilitation section of UNODC, who will kind of give us an introduction to the current version of the standards and a little bit about the quality assurance, and then we will have examples following up on how that is working at the moment. Wataru, floor is yours.
Thank you so much, Anya, for your introduction. Good morning, good afternoon, good evening, ladies and gentlemen, dear colleagues, friends. This is Wataru, UNODC program officer joining from Japan. It's my great pleasure and honor to be able to be here with you today. So in my presentation, let me give you an overview of the contents of the international standards and also development of a quality assurance mechanism and tools for their implementation. Next slide, please. Thank you. So the standards cover treatment settings like community-based outreach, non-specialized settings, specialized outpatient treatment, specialized short-term inpatient treatment, and specialized long-term inpatient and residential treatment, and also the science-based interventions, the modalities like screening, brief interventions, and referral to treatment, evidence-based psychosocial interventions, pharmacological interventions, and overdose identification and management, treatment of co-occurring psychiatric and physical health conditions, and recovery management. Next, please. First, let me talk about the treatment settings, community-based outreach, to identify target populations, engage and provide unconditional community-based services and interventions, encourage access to available treatment modalities. Services can include the provision of basic support, needle syringe programs, condom distribution, overdose prevention, information education, HIV hepatitis testing and counseling, and screening and brief interventions, crisis intervention, legal support, linkages to other services and support systems. Professor Poldis will be covering this part with a focus on the overdose prevention. Next, please. The settings are not specialized for the treatment of people with drug use disorders. To identify people, provide brief interventions, and refer to specialized treatment, what we call the SBIRT. Services can include mental health services, general hospitals, primary healthcare settings, emergency services, sexual health clinics, infectious disease clinics, HIV, hepatitis, TB services, and also social services and welfare agencies, etc. Next, please. And the specialized outpatient treatment is to help to stop or reduce drug use, minimize negative health and social effect of drug use, identify and manage comorbid conditions, provide psychosocial support, reduce the risk of relapse and overdose, improve well-being and social functioning as part of a long-term recovery process. Next, please. And the specialized short-term inpatient treatment is to diagnose and manage clinical conditions due to drug use, facilitate the cessation or reduction of drug use, including withdrawal management for short-term, and initiate the treatment of drug use disorders, motivate the patient to continue with treatment, etc. Next, please. The specialized long-term or residential treatment is to reduce the risk of returning to active drug use, maintain abstinence from drug use, improve health, personal or social functioning, and facilitate rehabilitation and social reintegration, learn relapse prevention skills. This setting is mainly for the severe cases with the experiences of relapses or multiple relapses, overdose, etc. Next, please. And with regard to the science-based intervention and modalities, SBIRT consisting of screening to identify people with drug use in non-specialized healthcare settings, mainly primary healthcare or emergency room, etc., using standard self-report tools like WHO Assist, and brief interventions for 5 to 30 minutes to enhance motivation to change or to provide individualized feedback, advice, offer of follow-up, etc. And also refer to treatment when more severe drug use identified, especially to the case managers, patient managers, or more specialized treatment for comorbid disorders, etc. Next, please. And evidence-based psychosocial interventions include CBT, contingency management, community reinforcement approach, motivational interviewing, and enhancement therapy, family-oriented treatment approaches like family therapy, and mutual help groups, etc. Next, please. Pharmacological interventions for withdrawal management by substance, opioid dependence using long-acting opioid agonist and antagonist, and symptomatic treatment for psychostimulant cannabis dependence, overdose identification and management, especially opioid overdose using naloxone, etc. Next, please. Recovery management is to maintain benefit in other treatment modalities by providing individualized continuous support and minimize risks associated with drug use, maintain abstinence or reduced levels of drug use, continuing treatment, or staying engaged with the recovery community, maintain contact with health social service network, and relapse prevention. Next, please. The standards also covers the population with special treatment and care needs. For example, people with polysubstance use, so people with specific health needs like comorbid health conditions and disabilities, and also children, adolescent, and elderly people with substance use or use disorders, the social care and support needs, women and pregnant women, and sexual minority, sex worker, religious and ethnic minority, indigenous populations, and people in contact with criminal justice system. For those populations, UNODC in collaboration with WHO and other international or experts have been developing so technical guidance document or guidelines or training materials, etc., which is widely available. Next, please. And also the standard outlined drug policy and the health system elements. Because we need to offer the most effective, least invasive, and lowest cost drug treatment interventions first, based on the amount of the populations with a different severity of drug use. So based on this tiered pyramid model, majority of the patient with mild or moderate drug use or drug use disorders can be treated under the self-care or informal community care or at non-specialized settings at the outpatient level. Based on that, we need to design the entire treatment system in cost-effective and efficient way. Next, please. Here, let me briefly talk about the development of the quality assurance mechanism and tools as one of the implementation tools of the international standards. Next, please. The background is UNODC, in collaboration with WHO, organized the international expert group meetings since 2016 to date, and the group reviewed the existing technical document, tools, standards, etc., and made recommendations on how to assess quality sections of the international standards. As a result, we are finalizing 2 QA tools for treatment systems and services, and also finalizing integrated key quality statement, which I will talk to you later, and the note about it sent out to the member states to understand more existing national QA mechanism and institutions. Next slide, please. These tools are to support the member states in assessing treatment systems and services and build capacities to institutionalize QA cycles and to provide technical assistance for improvement of the systems and the services, and also to be able to track quality improvement over time. Next, please. At this moment, we have mainly two quality assurance tools for treatment systems and services, because drug treatment system policies, planning, financing influence all services and patient outcomes. Next slide, please. For example, QA system assessment has 5 standards with 19 criteria, including the overall coordination mechanism, comprehensive needs assessment, whether the drug treatment system is in line with the tiered pyramid model, settings, modalities, interventions outlined in the standards, and the health financing, and also planning and monitoring mechanism is available or not in the country. Next, please. And the QA service assessment has 6 areas, 31 standards with 164 criteria, covering core standard with core management, core care, patient-right standards, and optional standards with interventions, settings, patient target group standards as applicable to specific treatment services. Next slide, please. This is a structure of quality assurance tool. Standard statement is there, and several criteria available, and scoring mechanism and evidence or data assessors need to collect and check when they visiting the drug treatment centers. As a result, we can produce colored scoring sheet to seek status quo and the spaces for further improvement at a glance. Next slide, please. And so in the course of piloting of the quality assurance, we identified the parallel QA works undertaken by some international or regional agencies and identified a huge overlap in quality standards, method, evidence, etc. So we agreed to develop a key quality statement for treatment services that are emerging and to be finalized shortly. Next slide, please. So far, UNODC completed full pilots on QA in Afghanistan and Nigeria, and organized the training of assessors in 12 countries, and organized the training of trainers online already. And the system QA project is ongoing in Pakistan, and the quality assurance project in 11 Latin American and Caribbean countries is also ongoing. Next slide, please. This map demonstrates where we have been working in terms of quality assurance and the implementation of the standard, and hopes to expand further in coming years to promote the implementation of the standards. Next slide, please. Thank you so much for being with us and for your kind attention. let me hand over the mic to the expert colleagues from Nigeria and Pakistan. Thank you so much.
Thank you very much, Batahu, for this quick run through the international standards and their implementation with quality assurance. And I would like to give the floor next to Dr. Auwal Salihu. He's the head of the Department of Psychiatry at the Aminu Kano Teaching Hospital in Kano State in Nigeria. And he will share his experience about quality assurance, implementing the standards at the service level in Nigeria. Dr. Auwal, floor is yours. Maybe you have to unmute your microphone.
Oh, sorry. Thank you, Anja. Good morning, afternoon, and evening, ladies and gentlemen. I'm presenting our Nigeria experience on quality assurance of services. This was from development of assessment tool for the quality assurance to the piloting and follow-up actions after the pilot. Next slide. This is a timeline. You can see from the March to August of the same year, the plan was to have training of experts for the quality assurance, development of assessment tools, and then to follow up actions, and then to feedback to services and so on up to August, and we were able to accomplish that over that time. Next slide. Kano was selected after developing the QA tool. And it was selected because Kano is located in the northwestern Nigeria and it has a population of over 12 million. And it's selected because it has the diversity, which is typical of Nigeria, with all the tribes represented within the same state. And then there are a number of state-run treatment services, as well as there was negative media attention a year before in one of the treatment services. Therefore, and there are drug treatment experts, and there are 2 national QA, quality assurance experts, members of the group. Next slide, please. The QA exercise. 15 treatment facilities were identified, and a letter of intent was sent for their consent to conduct the QA assessment. On arrival to Kano, the QA teams was divided into teams of 2 to 3 members each to visit each of these institutions that were selected for the piloting. 2 days each for the 5 teams was used to cover all the selected facilities. And at the centers, key individuals were interviewed. Case files were used case files were obtained and viewed along with various other documents. And physical tour of the facility was also conducted. Patients were also interviewed. So each expert scored the center on each criterion in the toolkits. 2 scales were used, the 3-point scale and the 5-point scales. The 3-point scales with the mates or partially mates and on mates. And then we use the colors also, the RAG system, the red, amber, and the green system. Then after returning from the visit, the 2 assessors wrote a detailed report and harmonized the scores between themselves. The 10 QA experts then shared all the report, and those who had not visited the center individually scored all criteria for the centers based on the reports. And the scores for each criterion arrived at by different assessors. Reading the report was then harmonized among all the assessors, and then a unified consensus score was arrived for each center on each criteria. Next slide, please. With exceptions of the other 12 centers are not drug treatment services. That's one of the findings, and the centers got variable scores, but in many aspects, they require tremendous improvement. Some serious negative findings there include the widespread use of restaurants by chains and stocks, and there was a report of unconfirmed sexual abuse in one of the female-only treatment centers. But many of the services were extremely dirty and unhygienic. And then there's lack of treatment for clients with mental health problems. And then where medication was provided for such client, it was often by unqualified staff. Next slide, please. Well, the follow-up actions, what was done after the pilot QA, contact was made with the management of the centers, that's the State Emergency Management Agency, the Health Service Management Board, and then American Teaching Hospital Management. And advocacy and briefings were held. Immediate actions and assistance to stop abuses and improvement of practice was made, a request of that. And then in particular, the unconfirmed sexual abuse was investigated by the QA team, and the management of the State Emergency Management Agency confirmed to us that they investigated the same case and punitive measures were taken on the individual involved some years back when it happens. Next slide, please. A two-day sensitization training was also held for the QA pilot sites managers, and they were supported to develop improvement plans with assistance of the QA teams, and then working with the Health Service Management Board of Kano State, with some medical expert and with the support of UNODC, some capacity building effort was undertaken to improve identification, assessment, and treatment of mental health problems among the clients, because most of the clients in those centers are mainly having mental health problems and few with comorbid substance use disorder, apart from the two centers that we said they are engaging in the drug treatment services. Next slide, please. Now, the implications of the QA exercise in Nigeria. There should be clarity about the scope of the QA so that certain things shall not be overdone. We, as much as possible in our interactions with the managements, various managements, and then treatment services managers, try to show that the QA assessment is to improve service. It's not for witch hunting or any other of such. And then revision of the QA mechanism and the tool and tools in light of the pilots that has already been done, because we have had some series of meetings after that to improve the QA assessment tool. And then capacity building of current QA expert, we hope that will continue, because continued education will improve that. Then future rollout of the QA, if not for the pandemic, by now we should have had additional QA assessment in some 3 or more sites in Nigeria, but we hope as the situation improves, that will be taken up. And I think there is potential for significant improvements in the drug treatment services provision if we continue to undertake the QA assessment. Sustainability, so the sustainability plans is a serious challenge, especially if there is no funding mechanism to fund it. And in the light of this, there should be a sustainability plans in place of the for the QA continuity in the country. Before I conclude my presentation, I wish to extend my gratitude for this opportunity to share Nigeria's experience by the organizers of this program. And I also thank the UNODC, specifically Hashes Bag, who is now in Cairo, Dr. Akani Banga, Annette de la Pereira, who has done tremendous work in training of the QA experts, and then my colleagues, the Quality Assurance Gladiators, as we name our group in Nigeria, without which this presentation would not be possible. Thank you very much.
Thank you so very much for sharing this experience on implementing the standards and using the accompanying quality assurance tools in Nigeria, and how you could show that what we said in the beginning, actually it was useful to identify even potential human rights abuses and has helped kind of to improve the quality of treatment, hopefully, or at least develop perspective for that. And as this was an example, so to say, at the service level, I would now like to give the floor to Mr. Sabino Sikandar Jalal, the Senior Joint Secretary of the Ministry of Narcotics control at the government of Pakistan, who will share about the quality assurance experience in line with the international treatment standards at the system level in Pakistan. Mr. Sabino Sikandar, floor is yours.
Thank you very much, Anya. I really appreciate this opportunity provided by NIDA and UNODC to present Pakistan's stance on the drug rehabilitation scenario in the country. I would just like to give a brief overview of the situation on ground in the country. If I can get my first slide, please. So these are a few stats that we have from a drug survey conducted with cooperation from UNODC. This was done sometime back in 2013. So I believe these figures are a little dated, but this is what we have till now. We have about 6.7 million people who are, we believe, addicted to drugs. Out of this, 4 million are on hash, and 78% of these are men, and 22% are women. And 4.25 million of these drug users are considered dependents. And this is an alarming number that about 430,000 people are ones who inject themselves with drugs. And 73% share needles and syringes. So this this statistic itself has a very disturbing angle to it when we realize that this leads to HIV and other dangerous diseases like hepatitis C and tuberculosis. So our situation gets pretty grim when we consider that this number has increased, I think, by 1/3 over the last few years. Next slide, please. The number of drug treatment facilities in the country are quite, I think, scarce and less than desirable considering our population and the number of people who actually require the treatment and drug rehabilitation. The total number of drug treatment facilities in Pakistan for about 220 million people are just 96, whereas government treatment facilities are 25, and then there are some privately run treatment facilities which are, as you can see, very little compared to the challenge that we face. Next slide. So these are the few gaps that we've identified with the, we conducted this feasibility study with the technical assistance from UNODC, and we really appreciate this effort and the support from UNODC, and I think financial support from our partners, valued partners, INLP. And these are the things that we've identified. We've found that there's a lack of standardized evidence-based drug dependence treatment interventions. Currently, the treatment facilities and the professionals, health professionals who use these facilities and treat people that do, they more or less use the symptomatic method. There is no standardized treatment facilities available in the country. So we're trying to work on that to develop standardized protocols for implementation across the country with help from UNODC, of course. There's lack of certified drug treatment professionals. There's lack of coordination and integration between drug treatment, HIV, hepatitis, TB programs, and other key stakeholders such as law enforcement, prisons, education, judiciary, social welfare ministries, department of civil society organization. So you can see that the gaps that we have identified and the scale of the enormity of the challenge that we face, it sort of multiplies when we realize that there's lack of coordination between the concerned departments. Next slide. So there's no mechanism for alternate to imprisonment for drug using people with charges of minor offense. This is very unfortunate that we have no other option but to incarcerate such people. There's lack of database based on drug prevention and treatment interventions. There's absence of monitoring mechanism. So you basically realize that this is, I think, one of the most neglected sectors within the public health sector in the country. Being a developing country, we have very little resources for public health, and this facet of public health, drug treatment rehabilitation, gets very little attention. So after all these years with this help from UNODC, which we really appreciate, we're now helping and trying to put some focus on this very neglected sector. Next slide, please. There's lack of scientific and evidence-based drug prevention interventions, as I said earlier, for educational institutions and community as well. So this is another very alarming challenge that we face. The drug problem, especially the synthetic drugs, they're more being adopted or used by our educational students in universities and colleges and secondary schools. So this is a very alarming trend that we're observing, this use of synthetic drugs. There's lack of drug prevention experts and professionals. There's lack of knowledge on prevention as a science. Next slide. So after realizing all these gaps within the system, we have formulated a strategy to address these issues over the next 5 years. We're committed to establish a mechanism to ensure quality drug treatment, drug prevention services in the country by strengthening coordination basically and networking between relevant stakeholders at the federal and provincial levels that can play their role in drug treatment and prevention. We're reviewing and developing drug demand reduction policies and strategies at the provincial and federal levels by the regulatory authority member departments. We're trying to institute some certification and accreditation of the drug treatment, drug prevention professionals and services at federal and provincial levels. We're monitoring drug treatment and prevention services, and we're trying to establish a mechanism for accountability of the service providers. Next slide, please. So the DDR quality assurance mechanism that we're trying to accomplish, we've already established a technical committee under I am the head of the technical committee, and we have all these relevant departments, the anti-narcotics force, the Ministry of Health, and certain other bodies, UNODC, WHO, and UNAIDS, and we're trying to firm up the different options that are available for quality assurance mechanism within the country. We've already drafted our legislative bill to provide the legislative framework and mechanism for drug prevention. And this bill is being sent to the National Assembly so that we can have a legislative framework available for us in order to implement this strategy and this regulatory mechanism. So we have already conducted trainings on DDR regulatory framework and mechanisms at national and federal levels and future levels by an international trainer, organized again by our friends at the UNODC. Next slide. The trainings and interviews were conducted in all 4 provinces with the senior management, psychiatrists, psychologists, and staffs of CSOs, healthcare commissions, health departments, public hospitals, Institute of Mental Health, AIDS Control Program, education departments, and social welfare departments. I think basically all the relevant stakeholders within the system. Next slide, please. So these are the key findings of those interviews, that quality of substance use disorder treatment, 56%, they consider that our response is quite poor, which is, we admit that it is quite understandable because of the reasons that I've explained earlier. And the quality of SUD prevention is also poor, and quality assurance body, the need for such a body is, everybody appreciates that there's a dire need to establish this body. And almost 96% of the persons interviewed then endorse this view. Then there's a quality assurance body for health, social welfare, education, and 57% of the interviews they supported that. Operationalization of quality assurance mechanism, 82% they consider that this is a dire need. Next slide, please. The current status on DDR regulatory framework mechanism is this, that we have established TORs and SOPs, and flow charts have been established. We've drafted our legislative bill. We've established a technical committee, and we're in the process of getting that bill through to the National Assembly for clearance. Next. So thank you very much for your time. So I would once again like to stress this point that with the support of UNODC and INL, we're trying to establish a groundbreaking, regulatory framework within the country. And until we started studying this aspect of the drug rehabilitation treatment and the feasibility work that has been done by the consultant from UNODC, these things were, I think, being a public policy practitioner myself, we weren't really aware of the gaps and these shortcomings within the system. We had these, sporadic outbreaks of HIV in the country and hepatitis C, but we were not able to pin it down to the to drug users and the persons who inject themselves with drug. But thankfully, with support from UNODC and INL, we now know the root cause of this problem, and we're trying to work it out. And hopefully, within due time, we'll come up with a framework that would be a game changer, not just for this country, but for the region as well. So thank you very much for listening to me. Thank you.
Thank you very, very much, not only for your presentation, but also for the leadership at country level, really to institutionalize quality assurance, and for having done this very clear analysis of the current situation with regard to treatment services and systems. So thank you very much, and we will continue to work together on that. With this, I would like to move, so to say, we've looked at the field testing, we've talked about the implementation of the 2020 version of the treatment standards through quality assurance mechanisms. But also I would like to give the floor now to Professor Paul Dietz, who is the Director of the Behavioral and Health Risks Program at the Burnet Institute in Australia, and who has worked with us on the UNODC WHO Stop Overdose Safely project implementation and the study in Central Asia and Ukraine, which in a way, in the framework of the international standards, gives us an idea of the implementation of the component on community-based outreach in the standards. But with that, Paul, the floor is yours to present the SOS study to us. Thank you.
Thank you for that introduction, Anya. It's a great privilege to be presenting. Good morning, everyone in the US, and it's 10 p.m. here, so it's getting quite late here in Australia. So if I could have the next slide, just a couple of disclosures. There's the key one is that I was an unpaid member of an advisory board for a Mundipharma intranasal naloxone product, but it doesn't really have any bearing on this presentation that I'm giving you. So if we go to the next slide, and if we just please scroll down the animation now. So as we've seen, there's a whole series of things that are connected to drug use around the world that are problematic, and overdose is one of the key ones, and it's a major public health issue that is preventable. And one of the key ways in which we can reverse the effects of opioids like heroin and fentanyl and others is through the use of naloxone. If we go to the next slide, please. And the WHO, in recognition of this, produced the Community Management of Opioid Overdose Guidelines in 2014 that really highlighted the potential for naloxone distribution outside of medical settings for the prevention of opioid overdose mortality. We go to the next slide. And that essentially underpins through a whole series of complicated policy processes the SOS initiative, which was established through the UNODC and the WHO. I guess for where I come into it is being involved in a multi-site study in Central Asia and Ukraine that really aimed to explore the feasibility and impact of what we call take-home naloxone with a focus on people likely to witness an overdose. And you can see the resultant SOS take-home naloxone kits there. They're about the size of a marker pen. Go to the next slide, please. Ultimately, they're all based on the SOS initiative targets, which are framed around a 90-90-90 framing that it borrows from bloodborne viruses and infectious diseases, where the cascade of care here is to try and ensure that 90% of people are trained in the use of take-home naloxone who might be exposed to an overdose. 90% of those people are supplied, and 90% of those people carry it with them. Can you go to the next slide, please? And here's an outline of the SOS project in and of itself. So there's a series of phases: assessment, preparation, implementation, and evaluation. And if we go to the next slide, I'll be talking about the implementation phase and the evaluation phase here today. And if we go to the next slide, please. All of the things that I'm talking about today are summarised in this report, which is now available on the website listed there. And it highlights the findings that I'll be talking about, but also it really does highlight the incredible achievements of what was an incredible team from each of the countries. And the national research partners really do need to take the credit. If we go to the next slide, please. Ultimately, the SOS program is essentially built on a training cascade that will allow it to be sustainable and scalable. So ultimately there's level 1 trainers who provide training to level 2 trainers who then go and train the people likely to witness an overdose. And so there's a scalable framework there that can be implemented in low and middle income countries, because most of our take-home naloxone knowledge is derived from wealthy, high-income countries. And they're the 4 countries there: Kyrgyzstan, Kazakhstan, Tajikistan, and Ukraine. And the aim of the program was to train 15,000 potential witnesses. Next slide, please. And as I said, there's the shot of the kit. And inside are 2 ampules of naloxone and syringes and necessary equipment to deliver the naloxone. We move to the next slide, please. And here's the implementation findings. So ultimately, over 14,000 witnesses were trained, over 16,000 kits were distributed, and a large number of people were trained to provide overdose response. And in an incredibly short time, a real testimony to the effectiveness of the team and the program. Next slide, please. And so moving on to evaluation in the next slide. Ultimately, there's a series of different activities undertaken, a process evaluation. I've sort of given you the figures that came out of that. Series of focus groups, key informant interviews that we're reporting on in different forums, and training data. But the thing I'll talk to you about today with the next slide is the non-controlled observational cohort study that we conducted as part of the rollout. And here's essentially what it looks like. The fundamental thing is that we collected baseline information before people were trained, and then we interviewed them again in 6 months to see what sort of impact the training had had on their overdose responses. Go to the next slide, please. The questions for today is whether or not 90% of trainees used naloxone at witnessed overdoses, an extension of the 90-90-90 target I mentioned previously. If we go to the next slide, here's, that didn't come through very well, but basically we recruited about 1,600 people into the cohort study, and you can see their main characteristics there. And we stratified for people who use drugs and people who didn't identify as using drugs. And you can see they're very similar to the sorts of cohorts you might expect to be using this, coming across people who might have experienced an overdose. If we go to the next slide, let's skip this one just for time. And fundamentally, the question, do 90% of trainees use naloxone at witnessed overdoses? So if we show the next table, you'll see very clearly that we had around 35% of the cohort have witnessed an overdose in the 6 months since they were baselined. And of their responses, just under 90%, so 89%, reported using naloxone at their overdose, and at the overdose they witnessed, sorry. And in 98% of those instances, the victim survived. So that's an incredible achievement in line with the target that we would want to achieve. So moving on to the next slide. What the SOS study has shown is that take-home naloxone can be implemented at scale using the protocol. I didn't present data on the training, effectiveness, but we know that the training works, and we'll show that in another publication. But importantly, the SOS participants use naloxone at these witnessed overdose events in line with those expected targets. So it's an amazing outcome from this program. If you move to the next slide. And so ultimately, we're looking at things to increase sustainability and uptake and scaling up in the countries that we're involved in, but also other countries, and making sure that we disseminate and implement the SOS training materials more widely. And with that, I'd just like to thank all of the people who are involved in the study, as well as the funders, INL, and hand back to you, Anya.
Thank you very much, Paul. And also here I have to say, not only for the presentation, but for really guiding us through the entire study and being patient with us in moments when it was challenging, right, with the study. So really, the SOS study is an incredible achievement. And thanks to everybody who contributed. And maybe for the attendees today, just to also let you know that there is an additional poster here at the CPDD NIDA International Conference on the SOS study that links you further through to the report. Thank you. And with that, it's my honor and pleasure to give the floor to our next speaker, who's going to kind of, in the framework of the international standards, present to us on the perspective or on the chapter on populations with special treatment and care needs from a clinical perspective. And that is Dr. Marta Torrens. She's the head of the addiction program at the Institut de Neuropsychiatria at the Addictionspark de Salut Mar Universitat at the Autonomous University of Barcelona. Sorry, Marta, for my mixture of English and Catalan. Over to you.
Thank you very much. Thanks, Anja, for your nice presentation. Good morning, good afternoon, and good evening. Thank you for the opportunity to talk. This is a next step for population with special treatment. And this is how to apply the standards for this kind of population. Then next, please. Next slide. Okay, this is in the international standards, there is population with special treatment and care needs. And in this chapter, there are some special population that are the pregnant women with drug use disorders. Then this is how to apply this and how to teach. This is one of the things that previous colleagues has talked in this morning, now. And I think this is very interesting to show our experience in this sense. Next, please. Next slide. Yes. Then this is the more relevant. The more relevant is that pregnant women with drug use disorder have a special need for treatment. Because first, drug use affects the woman, but the mother, but also the fetus. The second, that women that are pregnant has the same rights that women that are not pregnant when they have that drug use disorders, and in the opposite, in the vice versa, women with drug use disorders has the same right if they are pregnant that women without drug use disorders. This is the most relevant issues. Next week. Then this is how to apply this for teach all the persons involved in the treatment of a woman that has substance use disorder and also is pregnant. Then the models of the model has 5 components, that is the screening, the assessment, the treatment planning, and the treatment approach. Next, please. In the treatment, in the screening, this is very easy. It's just to say that all women that of childbearing age, when they came to treatment, that must be screened for pregnancy. And if there is some factors, relevant factors, like medical conditions, risk of withdrawal, or risk of harm to self and to others, she has to be treated preferentially. Next, please. then the assessment is very, very relevant to do the accurate diagnosis, appropriate assessment, and to develop the treatment appropriately. Next. Develop the treatment planning for we are focusing women with substance use disorder and also with who is pregnant. Then we have to be focused in the three situations, and then all the treatment plans is moving because the pregnancy is also moving, of course, and admits the collaboration of the obstetricians and gynecologists, and also after that of the pediatricians. Then next, then the treatment approach must have all these components: the patterns of use, the treatment approach must be evidence-based. This is very, very relevant. It must include the psychosocial interventions, and also the cultural. And one thing that is very, very relevant in this case, the stigma. Then that's very, very relevant. And also after that, the baby delivery protocol, but also very important, the postnatal postpartum treatment protocol. Not forget the women, not forget the mother, and also some recommendations about breastfeeding. Next, please. This is that they have to know if there is a neonatal withdrawal syndrome. They have to manage, they have to know that there is, and they have to manage the neonatal withdrawal syndrome. And next, please. That's the most important thing. And this is what we have done, to training the staff to all the members that are in direct contact with the patients, not only the medical or the physicians or also all the secretaries, the office managers. This is very important to avoid the stigmatizing of these women. It's very important that all the
Marta, sorry for interrupting. I just was informed that we will be cut off in 3 minutes automatically.
Yes, I know.
But you have still 2.
Yes, I know. Then it's very important to train all the staff. Then next, please. And this is why they have now, as others have said, we have to implement the WHO guidelines for that. They are, we have these implementers. Then next, please. We have to implement for this special population these guidelines to treat adequately. And we have very good experience in Ukraine, very good experience in Argentina, and very good experience in Ecuador. This is the next step from the standard, the international standard. And thank you. I finish here. Thank you so much.
Marta, thank you so much. I'm sorry for rushing you, and also to you, not only thanks for the presentation, but for helping us train women health staff already in various countries around the world. Thank you so much for helping us to implement this part of the standards. Christina, if I can just have the last slides, and then I will kind of come to a closing of this wonderful international session. Next slide, please. I just want to tell you what else we are cooking, what's the next that's going to happen. So we're about to develop additional quality assurance tools, especially with a view to medication-assisted treatment. Next slide. And I also want to let you know that based on this year's Commission on Narcotic Drugs, we have been given additional policy mandates by the international community to promote and disseminate the treatment standards together. So that's important. The new version has already been reinforced by political mandates. Next slide. And with WHO, we're looking at the even more comprehensive development of an implementation package of the standards to take them, in a very strategic way to country level and bring them to use, so that they will, as you see, they are already not, but that they will never be a document on the shelf, but a document that's really there to be used and to support countries. Next slide. I also would like to invite you, there is a network on quality assurance in drug treatment on the website of the International Society of Substance Use Professionals, which you can find at isap.net. Next slide. And I think with that, we come to a closing. We really thank you all so much for contributing to the development, to the implementation of the standards, and to take them into the future. As said, if you're interested, a poster on the international treatment standards and on the SOS initiative to stop overdose is available also in the NIDA International poster section. And last but not least, I thank really all the donors to the UNODC WHO program, especially INL, who has supported us in all the components that we've presented today. And I would like to thank again NIDA and CPDD for hosting us today and for all the speakers. Thank you so much, and thanks for being with us. Maybe we can just put the last slide of my presentation just to say goodbye. Thank you so much.